And by now, all of us are very well aware of Sir's accomplishments by the detailed description given a short while ago. So, without further ado, I would like to invite Sir to begin the session. The stage is all yours, Sir.
Good morning. I'm really delighted that I have the opportunity to talk to so many crowd about a topic which is very passionate in my career. I strongly believe that we dentists can transform the cancer or cancer care, and that transformation process starts from early detection. And I will tell you about some of the emerging trends in early cancer detection. Hopefully, you'll be able to take up some notes from this thinking. Before the meeting, I was talking to the chairman. He was suggesting that we should start a oral cancer early detection and surveillance center at the Royal Dental College. Such initiatives are important if you are to move the field of cancer forward. And congratulations for if you think about how oral cancer evolves, we all know that it starts from a pre-cancer stage to the cancer stage. And on a clinical front, we can see some of these pre-cancers are obviously clinically obvious as leukopenia or erythroplakia. But it's important to recognize that some of these lesions may be completely asymptomatic or clinically maybe normal mucosa can harbor. Then over time, that develop into invasive cancer. We all know that the histological progression of cancer from a non-dysplastic lesion to a dysplastic lesion to an invasive tumor. And recognizing that early dysplastic lesion is very important because the chance of transformation varies from the grade of dysplasia. Some of these lesions will have a transformation rate to 1 to 5%. Others have a transformation rate of about 30 to 40%. So this has a background as you clinicians how to detect cancer early stage and prevent cancer transformation. There are two critical approaches are there. It's very important to recognize these two as two separate approaches. One is screening and second is early detection. When we talk about screening, we are speaking about looking or identifying lesion at a asymptomatic stage. So you go to the population, you systematically screen in a defined population, identify that pre-cancer cancer stage. And screening means you are in early detection means in your dental clinic, if somebody comes with a lesion suspicious of cancer or pre-cancer, how do you diagnose that? These two approaches are important. When it comes to screening, these are the features important to recognize. We need to separate non-suspicious from suspicious. It should be a broad-cost approach, and we should be able to apply that in a population scale. When it comes to early detection, it's very important that we should be able to differentiate that low-risk type of lesion from a high-risk lesion. And it should be a point of care device because most of the time, if you ask them to go to a cancer center or hospital for biopsy, they don't comply. So it should be a point of care and should be able to separate, as I mentioned, from a high risk from low risk. I'm going to show you data from two publications from our state, which really changed my thinking, both from my mentor, Chandramarayan sir. He was the former head of cancer prevention at RCC and at IR. So this paper is published in a very obscure journal many years ago. I believe it's in 2003 or so. In this study, he looked at the outcome of oral cancer in India, Mumbai versus US. And he has shown that In India, the outcome is about 20% lower compared to US. That didn't come as a surprise. But if you go through the data much more detail, and you can see that if you diagnose cancer at an early stage in India, you can get almost same cure as somebody can get in US. I was just coming at 2003. I moved from US to here, and this was an eye opener for me. So if you diagnose cancer, you don't need any fancy equipment or anything. Early stage, you can get almost similar cure. Then their group has further showed in this very large randomized cluster randomized trial from RCC Toronto that you don't need any fancy equipment. You just have to train people. You just need a pair of trained eyes to diagnose them, not by professionals, by health workers, and showed that if you send trained health workers to the community, you can lower the mortality by about 15%. No intervention, no fancy immunotherapy or surgery have this kind of impact. Now, he has shown the way to move forward. This was the cover article of Lancet in about 2004 or so. And but if you look at what happened to that journal article, it stays as a paper in the library. It does not apply. Now, I mentioned at the beginning that the knowledge which we can apply is meaningless. So how do you take the knowledge which is applicable to impact? And if you look at the diagnostic adjuncts to diagnose cancer, there's a lot of us get into this, and there are multiple of them. And if you summarize all this diagnostic adjunct is to empower people at the care to provide almost accurate diagnosis as a specialist point of care. And essentially, it's a connecting or giving an equivalent diagnosis at the point of care compared to a specialist. And if you think about all the diagnostic adjuncts which I mentioned in the step before, they can be visual, just looking into the lesion, or some kind of light-based diagnostic adjuncts or other staining techniques and so on. If you summarize all this, they are images you see or a device see. And if they are images, you can digitize them. If you can digitize them, you can send it remotely. Even more importantly, you can even bypass a specialist and using AI ML, you can get a point of care diagnostic even without the specialist interpretation. Let's see how that can be utilized. So that Dr. Shankarnarayan's thought was in the back of mind, and pursued this from about 2008 onwards. And this is one of our first publications. By Root in our medicine person, published in 2016, but study started in about 2008. The idea was whether I can replace the eyes of a specialist with a camera of the phone. I will not go into details of it. Essentially, it asks you questions, take images, and send to a remote specialist to interpret that image. And then we put that concept into a test. About 4,000 odd individuals were tested. I will not go into details of it. Essentially, it has shown that if you give that phone to a dentist, the accuracy is almost 100%. But we cannot send a dentist to the community. But if you use the health worker, the accuracy dropped down to about 10%. So the technique did not work. Now we didn't stop at that time. Then there are a lot of problems associated with that. So we thought about how to improve that technique. And then the first thing is that imaging probe should not be a camera, image from outside. It should be attached to a probe. And it should not only be a white light. We need a combination of white light and photofluorescence and soft signals. But the interpreting that well scope needs a specialist like you and me to do that. That again cannot be taken to the community as a point of advice. That is when we talk about bringing artificial intelligence to image analysis. Now, artificial intelligence, people think that's a complete thing, and so on. put it that it's just nothing other than identifying pattern recognition. Now, let us say in this image, I want to identify a bicycle. Okay, so what should I know? I should know what are the bicycles, what are the images of bicycle. And we should also know what is not a bicycle. That also is important. And if you identify these two, then it's very important. It's very easy to identify the bicycle. Now, let us say how to identify the bicycle in a boy riding a bike in the picture. Does it have a similar picture in that map, that sheet? Then the image needs to be interpreted. That's how you and I can recognize as a bicycle. So how can the machine can identify? Essentially, it undergoes two processes called segmentation, and the other one is called the image classification. I will very briefly go through that. We can read up about it. So essentially, this has got how do you identify the bicycle which is lying there within that image and recognize as a bicycle. It has got three processes. One process called convolution, second is called max pooling, and third is called review or rectified linear unity. I will come to that each of these in a minute. So let us say if I need to identify the two, the computer need to identify two as two, what it does is a segment that forms into multiple layers and identify where that number two is written. And then pull that image, that the slides where the images where the number two or part of the black part is written, and that is called max pooling. And the last is interpreting that two is two. Okay. So this has been used extensively in medical field. For example, large number of chest X-ray nowadays are read by image analysis, goes through that the convolution, and then we have some max pooling, amplify that where that number two is there, and goes through multiple layer of convolution and to max pooling, and then review, rectify linear units, and tries to identify how number two is. This is how the brain thinks. So the brain thinks by recognizing, let's say that you identify me as Moni Kuriakose. How do you identify me as Moni Kuriakose? Say somebody like Bini Raj, within a fraction second identify me. But somebody like you, what you do, you segment out all the other the background noise and just focus on me. And since you have heard that I'm from a dental background, you narrow it down and say that somebody you think about it and slowly identify me as me. So that is how the brain thinks by a lot of negative feedback to interpret one image as some meaningful image. So we applied that image analysis in our data analytical platform. We use two separate algorithms. One algorithm can be used by a computing power of a phone. The other one we send to the cloud and use the computing power of the cloud. And then this is how the image is identified by the specialist and by the AI. And then we tested whether this can be applied in clinical practice or not. This is a large randomized trial we did in the community setting. About 5,000 teachers were enrolled in this study. Essentially, use that probe, then empower the people with that probe, and then the health workers with the probe. And then this image was taken, and the computing power of the phone interpreted that lesion, what that lesion is, and some of the images were sent to the cloud, and then cloud interpreted that data. And we also have specialists going to the community to say what that lesion is and compare that data. So this is summary of that last study. Showed that if you just use a frontline health worker, the accuracy about 70%. Using the phone neural network, it's increased to about 79%. And if you use the cloud network, it's 87%, fairly close to you and I can diagnose. This is just using 5,000 patients or 35,000 images. Imagine if you have a large number of data sets, it can come as close to what you and I can diagnose. So that is some of the emerging trends of screening as a strategy. Second is about early detection. Early detection means somebody has come to your clinic and you need to identify that lesion is a pre-cancer cancer. So you need a pathology equivalent diagnosis. So how do you give a pathology equivalent diagnosis? You ask them to do biopsy. A lot of patients will not comply to that. So we ask the question, simple question, whether I can take a cytology image and send the cytology from point A in your clinic to a remote specialist sitting in a dermatologist somewhere. A simple question we ask, and then we use two pathologists because we know that intraobserver variability is fairly high. And if you look at the two graphs on the top, one of the pathologists could not differentiate a pre-cancer from a cancer. One pathologist could do that, but overall, the accuracy of a direct microscopy about 63%, and the tele cytology was almost similar, 62%. That shows that tele cytology works only for cancer. When it comes to dysplastic lesion, did not work. Now the question we ask the question whether we can bring up the AI ML to identify or not. So for this one, we again took cytology images and then segmentalized manually, and then developed what we call dysplasia score. And then the higher the score, more chance it is a cancer. The lower the score, it's a pre-cancer condition. So we used about 12,000 images, 6,000 typical cells, and 6,000 normal cells. And just to summarize the result, the accuracy for cancer, similar to the direct microscope, about 93% sensitivity, specificity about 88%, dysplastic lesion, which increased to 73%, and the specificity is about 100%. This is by directly segmentalizing human by human and making a diagnosis. Now, this cannot be done in a clinical practice. Ask the question, we can bring in AI ML for that or not. So this is a slide. If you look at the slide, fluorescent slide under the microscope, this is how the slide looks. And then our job is to segmentalize out of all the cells you have, which are the clumps, which are the debris, which are the clusters of cell, epithelial cells, which are the single epithelial cells need to be separated, that pattern recognition which I was talking about. And this has got to be put that into test in about 133 patients. I will not go into details of that. By the way, this is a work of Samson I was talking about. That's his work. So we asked the question, they can auto-segment it, okay, and they use the decoder, encoder, or I'm not going into details of that. So essentially, we ask the question whether they can separate out the single cell, epithelial cell, or cluster of cells, and then we use UNET, one of the CNN algorithm, to differentiate that, separate out the epithelial cells from all the other the debris and so on, and also separate out and then extract the features. What are the features of dysplastic cells? I earlier mentioned about the rate of dysplasia score based on nucleus cytoplasmic ratio, intensity of the epithelium and so on, nucleus and so on. So putting all together, this could identify sensitivity by putting the computer to tell us whether it can diagnose a dysplastic cell from a cancer was 87%, specificity was about 87, 82%. I will bore you with details. We went about and see whether we can bring in molecular cytology. We want to increase over 90%. Let me not get into more details of that. That further increase using AI ML algorithm. Now, suspecting a lesion is one thing, but taking the patient through the care pathway is more difficult. Let me give you the example from PALAKKAD. So this patient is from PALAKKAD, one of my patients. He was an IT, still an IT professional. He saw with this lesion that done about 6 specialists in various settings, and then got diagnosed with cancer. By the time diagnosis became stage 4, not because of any lack of compliance of the individual, but we as a profession failed. Okay, so how do you? And then patient went to a cancer center. Since it was seen by a medical oncologist, got chemotherapy instead of surgery, so the treatment also did not get that treatment. But if you look at the path a cancer patient to take, it's extremely complex and convoluted. And this is what over 1 million of our patients have to go through. Now, whether we can simplify that process or not, whether we can bring in technology to simplify or not, this is what our group is doing now. Whether we can digital, our Haji sir mentioned at the beginning about how transformation is happening in healthcare, and we try to use that technology. So what we have done is that we developed various applications for screening. Then one screen, how to care coordination, how to bring in a virtual tumor board, and then care coordination. And if you look at the technology behind all these applications, almost like the back end of Amazon. Amazon is a logistic company, exactly like logistics is what is required for care coordination. So 3 layers are there, various applications at the top. Then this data need to be pulled into the hospital information system, and then this data need to be pushed into what we call K-cloud. And most of the data are unstructured data using natural language processing, making the structured data so that it can make sense out of it, and then integrate with the various care providers. So I will not go into details of that, but if you do that, you can convert almost any hospitals into what we call community cancer center. And the care coordination can be done by what we call it as a command center. I will just give you some details of this, the effectiveness of the technology platform. During the last 18 months, we have risk evaluated over 1 million population. Out of that, about 12% had elevated risk for this pre-cancer or cancer. Just want to take you to one of the latest we have done it in Kuriakose in Turkey. Population about 10,000. Out of that, about 7,000 existing manpower by the primary health people. Using the technology, we could risk evaluate, and about 60% underwent that risk evaluation during that 6 weeks of our activity. And just want to look at that table on the right side, we could impact the life of about 200 people and prevent cancer or early detect and intervene. So imagine here, 74 wards of the cancer center to the community, convert the cancer, the community as a cancer center. Just last illustrated case is a patient with a bleeding from the nose, a chest axis, recognized as a abnormal sign, sent to an ENT surgeon, did a biopsy, which a tumor board was convened and mentioned that it's a sinus and undifferentiated carcinoma. Then the patient required chemotherapy. Chemotherapy was given in a hospital in Italy, and then only for surgery came to one of the centers in Ernakulam, and only for radiotherapy they actually went to a cancer center. So entire care could be coordinated by this kind of approach. So finally, ladies and gentlemen, technology can transform cancer care. I mentioned about oral cancer early detection, screening methods I mentioned, early detection method I mentioned, and also the care coordination. Just want to thank the people who done the work. I mentioned Samson. Most of the cytology work was done with Samson during his PhD program under collaborators across the world. Thank you so much for your attention.
Thank you, sir, for that enlightening talk. I would like to request our chairpersons to kindly give their brief concluding remarks.
Thank you so much, sir.
very quick and very detailed and very interesting presentation. Um, you have already started this meeting, is what you said, right? And you think it is doable? It is doable in other areas of Kerala.
Yeah, not only Kerala, our goal is pan-India. Yeah, so we took Idiki because that's one of the most difficult. Idiki is a district without any cancer facility, extremely difficult to navigate. So we went to Idiki because of that. We can prove that works in Paliwatan. I'm sure it will work in that.
As a dental institution, what would be, where would we come in that level?
So I was see that's it's extremely important. See if you look at the entire cancer hierarchy, what we are trying to do is integrate cancer care with the regular routine clinical care. That is where people doesn't go to a RCC Trivandrum say that I need to get diagnosed with cancer. So it will go to one of the people go to one of the dentists like the case which I showed. Then if you ask them to go to RCC Trivandrum, they will not go. But if you ask them to go to a dental college for a biopsy or even the pathology interpretation of dental college, they will be happy to do that. And you have a large manpower to do that. And rather than depending on, say, some pathology lab, you have facility there. And you have manpower to work with the dental dentists around the community. So make a cluster with the dental college as the hub and work with the cluster. And that can transform that particular one small region. Show that works in small region, then it can be expanded throughout.
So just for the clarity of our duties, the basic the doubt comes in the dental clinic, maybe in a private setup, or maybe even in the OMR department. The doubt comes, and they are sent to the dental institution for the check. The dental institution checks it. Maybe they discover something on biopsy on the swab. After that, will they go to RCC or will they go to a cancer center? You're saying they won't. So after that,
yeah, so that is extremely important because when I was the director of COCHIN Cancer Center, I looked at all the screening camp carried out by the cancer center. Okay, about 200 odd camps they done. They suspected a lot of lesions. Hardly any patient went to hospital for treatment. Okay. Now, what's the reason behind that? Nobody wants to get diagnosed with cancer because taboo attached to that. Okay. Now, if there is somebody to handhold that person to push that, technology doesn't work that way. Technology needs to empower people next to you. That's why we developed this command center where we empower a local dentist or a community worker or pain and palliation nurse. We call it navigators. We train that person to navigate them. We ask the person that you have a decision, need to undergo biopsy, and then we send reminders. So we handhold them to move to the next level. And once the diagnosed cancer, we say that there will be several reasons why they're on hold. We handhold them. We means the community. We use the community manpower to the transformation.
So, for example, maybe we could use the local ASHA workers.
Absolutely. Yes, absolutely. Absolutely.
Okay, so we kind of associate with the local ASHA workers and get them to come to us or to a local dentist who sends them again to our institution. And from there, we take it on. Maybe we send them to a local center, it's a minor issue. If it's a bigger issue, we send them to a center.
Absolutely. Yeah. And to standardize that, you need technology. Because ASHA workers, how do you ensure that ASHA worker in Palakkad does the same thing as somebody in Palakkad? So that is why standardization needs to happen in technology. We need a certain testing. If that happens, empowering that ASHA worker to be almost as good as somebody, a navigator sitting in cancer. That is feasible with technology.
So we will look forward to liaising with you to get some input on this in the guidance.
Thank you. Thank you. Thank you so much.
Thank you, sir. Thank you, ma'am. I now request the chairpersons to kindly come on stage to present our speaker with a token of appreciation. I would now like to request Dr. Rishi Amati to hand over a token of gratitude to our chairpersons, Dr. Anuradha Sunil and Dr. Mohammed Sagir. We can all have a 10-minute tea break right now. The tea is served right at the back of the hall. I request all delegates to have the tea and be back in 10 minutes, please. Okay, there's another good news. Practitioners delegates, there are 3 samples of toothpaste right there inside. Delta 91, so you can also take a sample of it, and it's for free.